Well, welcome back, everyone. I'm Pat Camillo, the creator and presenter for this program. In this section, I'm going to be focusing on depression and estrogen. I've been touching on serotonin in previous sections because it's such a major neurotransmitter. It plays a role in so many brain diseases. But with depression, it's an especially important player. It takes a real starring role in the underlying pathology associated with this disease. So this section will get a little more in depth about the estrogen-serotonin connection. I'll also share some of the current thinking about using estrogen to treat depression. And in addition, I'm just going to talk a little bit about how testosterone and progesterone interplay in all of this. And last but not least, I'll share why phytoestrogens can be helpful in managing depression. But before I get into the weeds with serotonin and estrogen, I wanted to just provide a little overview about what depression really is. So, if you're stressed out and you're feeling anxious, that could definitely be depressing. But that's not the same as clinical depression, which is a very serious condition that can literally lead to someone's death. This is not about having a down day once in a while, nor is it about someone sitting necessarily in a corner and crying. Nope. When someone is depressed, they lose interest in things that used to interest them or give them pleasure. Their energy levels are low, and they're not very motivated to do much of anything. Depression can also interfere with sleep, eating, and a person's ability to concentrate. Many who experience depression also have feelings of low self-esteem. They may outwardly appear fine and even be quite functional, but inside they're not okay. And sometimes they're even irritable and angry. Not the kind of thing you'd typically associate with depression, but could definitely be a part of that picture. There's an old saying, when depression turns outward, it shows up as anger. It always makes me a little crazy after those school shootings to hear people say they'll never know why or what the motives were. Well, there may very well be motives and even planning, but the underlying cause is a brain disease that's gone undetected and untreated in many of those instances. Many times these kids will be dressed completely in black, and witnesses will tell you that they showed no emotion when shooting. These are people with serious brain diseases, and it's clearly part of, depression is clearly part of that clinical picture. I also just want to touch a little bit on the history related to depression and estrogen. This is a quote from a textbook that some consider the first textbook of gynecology, written in 1923. Novak states the following about women in menopause. They are peevish, irritable, morose, and depressed. Many have full-blown insanity with melancholia, paranoia, and maniacal conditions. There are so many things that are problematic with this statement, not the least of which is that he associates psychopathologies with menopause. The quote in this textbook represents a very medicalized and pathologic state of menopause and implies that all women experience it. There's actually quite a long history of connecting women's hormones and specifically menopause with depression. Most of this was not okay because it was not based on good research, but rather on social and cultural pressures to try and keep women in their place. By the way, if you want to learn more about the history of depression, which, trust me, is so fascinating, let me know in your evaluation. Most importantly, depression is not an issue for all women, whether they're in menopause or not. It's important to remember that throughout this program, and with every disorder I'm discussing, some women will simply not experience the same issues as other women, even when their estrogen levels are low. And this is because we're all hormonally unique. In the previous section, I discussed some of the genetic polymorphisms associated with anxiety. Well, they also exist for depression, making these concerns a much bigger issue for some women as opposed to others. So you would think that from 1923, in the previous slide, we would have come a long way by 1968, but nope. The second edition of the Diagnostic and Statistical Manual for Mental Disorders, known as the DSM, included a mood disorder called involutional melancholia, a diagnosis specific to menopause. It was removed several years later because in a review of longitudinal studies, they found that this diagnosis was based on research that focused on depressive symptoms and not on an actual diagnosis of depression. We all have symptoms of depression from time to time, often related to situations, but that's not the brain disease referred to as clinical depression. And so when you read research, it's really important to take note of what criteria was used to define depression in recruiting participants. In one interesting study, the Penn Ovarian Aging Study, they reported an increased risk for depressive symptoms in perimenopause, but found a subsequent decline postmenopause over 4 years of follow-up. There really is a light at the end of the tunnel. Without a doubt, when I think about all the women I've seen over the years, either for individual consultations or in group presentations, the vast majority tend to be in the perimenopausal age range, and certainly never more than 52, 53, I would say. And as a woman myself, now in her 60s, I can also testify that it really does get better. It reminds me of the menopause experience found among rural Mayan Indians. They don't really have a perimenopause because they're either pregnant or lactating most of their adult lives. And so they never get another period after breastfeeding what's often their 10th or 12th child. So they consider menopause a time when they're finally young and free. Now that's a whole different perspective and also a very different biology. Okay, so now let's take a look at the statistics for depression. This graphic comes from the CDC and was taken from the National Health and Nutrition Exam Survey from 2013 to 2016. And believe it or not, that's the most current data we have because it takes them forever to get these results done and published. It's obvious when you look at this that in every age group, significantly more women are suffering with depression than men. Also very interesting, when you focus on women alone in the graph, you see that the biggest bump in depression occurs between the ages of 40 to 59. These are the years when estrogen starts to drop. Additional evidence can be found in the findings from the Harvard Mood Study, where they reported an increase in depression rates by about 16-fold in the 42 to 52 year age group. Now, if that's not bad enough, in addition, CNS changes have been found to occur 5 years before hot flashes and even amenorrhea. And that would be between the ages of about 43 to 55. So, on the upside though, if you look carefully at the graph on the slide, you'll see once again that there's a decline in depression from age 60 and over. My personal theory, based on some research, is that the brain ramps up its personal production of estrogen in response to lower plasma levels. And as I mentioned, there is indeed some indication in the research that it does respond to lower plasma levels of estrogen. And of course, there's never just one thing going on. There are sociocultural factors that need to be considered, especially as one ages, even though there are some issues that are resolved, such as not having adolescent children anymore. But there are others, such as chronic illness and the loss of friends and family. So there's a lot going on. As I often say, it's complicated. But clearly estrogen is playing a significant role here. And none of this, by the way, happens overnight. It takes time. And remember, not every woman experiences depression. The majority, in fact, of perimenopausal women do not experience significant depression, even though there is a 2 to 3-fold increased risk. But like I said, so many of these issues can get complicated. For example, women also often complain of sleep disturbances during this time, and we know that not getting enough sleep can definitely increase one's risk for depression. When you don't get enough rest, you're much less likely to exercise, and that's another risk factor. Hot flashes have been highly associated with the incidence of depression, just as they are with anxiety. Makes sense, right? Because low levels of estrogen leads to wacky temperature control in the hypothalamus. And once again, you will find that the hypothalamus in your brain is responsible for so much more than the ovaries. Now, I showed you a similar graphic earlier in the program, but it bears repeating as we further discuss the relationship of serotonin with estrogen. Estrogens increase brain serotonin, mainly by decreasing the activity of MAO, which is responsible for serotonin catabolism, or the breaking down of serotonin. So estrogen basically acts like a MAO inhibitor, very similar to some of those older antidepressants on the market. Estrogens also increase the serotonin receptor 5-HT2, which is really helpful because this receptor mediates serotonin's antidepressant action. So just like estrogen receptors, serotonin has a receptor. Women who have experienced a major depressive disorder in the past are much more likely to experience it again. And this too makes sense given the underlying physiology that's going on. Interestingly, the Harvard study of moods and cycles found that women with a history of depression had a 20% increased rate of starting menopause sooner than women without a history. And of course, this also makes sense as we connect the dots because that's when estrogen levels are going lower. In that same study, researchers also found that even women who had no history of depression were nearly twice as likely to experience depression during menopause compared to premenopausal women. The estimates are that 20 to 40% of women will develop an episode of depression sometime during the menopause transition. Now, that's still far short of saying that all women will experience this, even though these are pretty substantial numbers nonetheless. And once again, there is an upside. In the Melbourne study and the Norway Hunt 2 study, when things settle down and women are in postmenopause, the incidence of depression is lower. And I'm a big believer in recognizing that our bodies will always try and find balance. I want to emphasize here, at this point, that you can't really determine whether or not a woman is running a risk or is currently experiencing an estrogen-related depression based on serum levels of estradiol. I want to emphasize this because I get this a lot. People want to have their blood drawn. But remember, the brain is an independent producer of estrogen, and this will not be reflected in serum levels. So, how do you know? Well, it's just good old-fashioned history taking. Ask questions. Is there a history of depression, especially a history associated with hormonal changes? Was there depression premenstrually, postpartum? These would be strong indicators identifying risk for an estrogen-related depression. What are the possible life stressors that might be impacting the current situation? Keeping in mind what I discussed about the relationship between stress, anxiety, and estrogen. So even when there are significant life stressors, it still all boils down to chemistry. Remember how we get cortisol through channels from the hypothalamus to the pituitary and finally the adrenals, right? The same mechanism that we see in stress and anxiety appears to be at play with depression. It turns out that most people who are depressed have high levels of cortisol on a daily basis. And although cortisol is normally low in the evenings, it tends to run higher than normal during those hours when women are depressed. Take a look at the graph on the slide. The dotted line represents women with major depressive disorder. These are often individuals who experience a slump in the afternoon, but then really perk up in the evening. A certain amount of that is normal, as you can see on the slide. For example, I never like to do a presentation in the afternoon for that very reason. But this circadian effect is substantially increased in women with depression. In another study I reviewed, circadian cortisol and estradiol rhythms were monitored in 27 women. 12 had a diagnosis of major depression. They were compared to a control group that didn't have depression. As expected, both cortisol and estradiol demonstrated clear diurnal rhythms. In the control group, the acrophases, which are basically the peak levels of cortisol and estradiol, correlated. But the acrophases in the depressed group demonstrated no correlation in the late luteal phase, a time when estrogen levels are low. This may suggest a coupling of cortisol and estradiol that might be present in healthy participants, but not in depressed women. A decoupling of the cortisol and estradiol phases may suggest a phase misalignment in depressed women. I love looking at circadian rhythm studies. I find it so fascinating that the body has such rhythms going on, and we could learn so much from that. So the impact of cortisol on depression is especially evident as women get older, because of course estrogen levels are also lower. In a meta-analysis of 20 studies that looked at the association of depression with cortisol dysregulation among older adults, and we're talking over 60, those with depression displayed higher levels of basal cortisol during all phases of the diurnal 24-hour cycle, but particularly during the evening and night hours. It's not easy to get to sleep when your cortisol is running on the high end, and this can certainly help explain a lot, particularly in this age group. Now, both SSRIs as well as cognitive behavioral therapy have been shown to help reduce total cortisol, and this likely is a major contributing factor behind how they actually work. Okay, I've included a few slides here from a wonderful group in Australia at the Alfred and Monash University. Dr. Kulkarni is a professor of psychiatry there and has done amazing work in this field. This slide basically sums up some of the main content I've been discussing so far in the program. Estrogen plays a very important role in modulating so many of our neurotransmitters. I talked already about how it works with serotonin, with dopamine, norepinephrine, and cortisol. And because of its intimate connection with all of these, estrogen is very neuroprotective, especially with stress. And as you've seen so far in the program, when stress is dysregulated, that can lead to lots of other brain diseases. And here's another slide from the same group addressing the use of antidepressants during perimenopause. Her point is well taken here, and that is we need to match the choice of treatment to the symptoms. Depression is expressed in so many ways. For some women, it's a loss of sleep. For others, feeling angry or irritable. It's not always about looking and feeling sad. In fact, in my clinical experience, that's less often the case. Because of this variability, it really does matter which antidepressant is prescribed. So fluoxetine, otherwise known as Prozac, could potentially make irritability worse. But agomelatine could make it better, and it could also help improve sleep. It's an atypical antidepressant in that it works on melatonin, which is a whole nother interesting study. And let me tell you, sleep is an incredibly important factor in brain health. I recently read a book called Why We Sleep by Matthew Walker. He's a neuroscientist at UC Berkeley. Fabulous book. If you have any free time, get it and read it. Maybe as bedtime reading. I don't really dabble much in psych drugs. I'm much more inclined to explore ways to enhance a woman's estrogen. Because given what I've discussed so far, you could probably understand why. One of the champions for this alternative approach is Professor John Studd, an OBGYN with amazing credentials and who now runs a clinic in London helping women with PMS and menopause-related conditions. He believes that psychiatrists have little idea how to treat depression in women because they refuse to learn how to treat estrogen-responsive depression. He's quite outspoken, and he doesn't hesitate to share his views about this. So there's a bit of a turf war going on here between the psychiatrists and the OBGYNs. And women, unfortunately, are getting caught in the middle. Currently in the U.S., estrogen is not specifically approved to treat depression. However, it is being used off-label at times for this purpose. The reason is based on clinical anecdotal reports from women and also some small studies that have demonstrated that it can indeed make a big difference. One study that was done at the National Institute of Mental Health recruited 56 postmenopausal women, 26 of whom had a history of depression and 30 who had never been depressed. Each of the women were given an estrogen patch to wear for 3 weeks and then tested for depression. None of them were positive for depression. At the end of the 3 weeks, the same women were randomly divided into 2 groups. Both groups were given identical skin patches, but one group's patches contained estrogen and the others did not. The women wore these patches again for 3 more weeks, and their moods were once again evaluated. The women with a history of depression who got a placebo patch scored significantly higher on the depression scale when they were no longer wearing the estrogen patch. In all of the studies I reviewed, the estrogen patch was used. However, that can get complicated if a woman has a uterus. There's a need to add, of course, progesterone to ensure that the lining of the uterus, which is stimulated by estrogen, doesn't start growing a bunch of bad, potentially cancerous cells. Progesterone antagonizes estrogen, so the problem is it might cancel the beneficial effect that estrogen might have on mood. For some women, estrogen alone can alleviate depression. For others, a combination with an antidepressant works better. Every drug has its side effects and possible negative consequences. And although estrogen is often associated with blood clots and strokes, serotonin-enhancing drugs used to treat depression also have significant concerns. Smaller and colleagues in 2009 published findings that showed a 45% increase in stroke, a 32% increase in all-cause mortality, a 2% increase in fatal stroke, and a 212% increase in hemorrhagic stroke in women taking antidepressants. Now, this is not a cause and effect kind of thing, and so there could be a lot of, confounding variables in the mix here. But you add to that studies have only shown a 60% rate of effectiveness for antidepressants, and it gives you something to ponder when you're comparing the both of them, the estrogen and antidepressants. When the antidepressants work, they work great, and the benefits clearly outweigh any risks if they're working and they're helping that person. So there are two other hormones that dance around with estrogen when it comes to depression, and I just want to touch on them a bit. Progesterone. It's, of course, a major sex hormone. Its claim to fame is more closely associated with reproduction than anything else, but actually, just like estrogen, there are progesterone receptors that are broadly expressed in the brain. So what does it do? It's been found to be anti-inflammatory and has actually been used to treat multiple sclerosis. It helps to regenerate myelin sheaths. It's also involved in the brain, helping it to repair itself after a traumatic injury. Pretty incredible stuff. So it's an important hormone and should be respected. But there is also a problem with it. As I mentioned in the previous slide, when it's taken together with estrogen, it can cancel out the beneficial effects that estrogen brings to the brain. We know that even in the menstrual cycle, progesterone modulates estrogen. So these two hormones do have a tendency to bump up against each other for better, but sometimes for worse. During the second part of the menstrual cycle, progesterone helps to bind together the lining in the uterus that estrogen supplied earlier in the cycle, and in doing so, it prepares a nice bed for a possible implanted embryo. So that's good. But on the downside, there are some women who are especially sensitive to progesterone, and it has some less desirable effects on them. I often refer to progesterone as a downer because if you get enough of it, you'll feel sedated. You see its effect premenstrually in some women who might tend to feel depressed when progesterone is at its highest. Progesterone also has a confusing history with mental health. Dr. Anna Dalton was a British physician. I think she recently died in 2004. So not that long ago. She was the first physician on record to use progesterone for the treatment of premenstrual syndrome. She found it to be really effective, but there was a catch. Just because it helped reduce the anxiety and agitation that women were experiencing premenstrually doesn't necessarily mean that these women had a deficiency in progesterone. Dr. Dalton was using very high doses that were injected directly into women. So it is much more likely that the positive result she was noting was a drug effect rather than a cause and effect. Clinicians are sometimes tempted to give women OCs as a fix for some of these negative premenstrual symptoms, and sometimes that works. But, it's like throwing a dart up against the wall. It can be a problem. The Danish pill study reported in 2016 confirmed that progesterone-only contraception and the pill in general were associated with developing depression in some adolescents who were, potentially sensitive to progesterone. So again, it's never going to be all because we're so hormonally unique, but there are segments who are going to be negatively affected. And there's really no good way to know who that might be except through a careful and thorough history. The focus of this program is on estrogen, so that's about all I'll say about progesterone. But if you want to learn more, let me know in your evaluation. Estrogen, as opposed to progesterone, is an upper. It's the feel-good hormone. The second hormone that I want to touch on a little bit here, not much, that dances along with estrogen in regards to depression is testosterone. The two things that testosterone is especially known for is libido and mood. This slide provides a general idea of the levels of estrogen and testosterone in both men and women throughout the lifespan. But here's the problem with these kinds of graphs. The amount of bioavailable testosterone is very dependent on the levels of sex hormone binding globulin, or SHBG. This binding protein has a real affinity for testosterone. And remember, when a hormone is bound by a protein, it's no longer free and can't bring any of its effect to the party. So SHBG also binds estrogen, but it does so in a much less way, much less effect. So it is really the binding of testosterone that will determine how much of an effect testosterone is going to have. There are quite a few lifestyle variables that can actually tweak one's sex hormone binding globulin. Things like how often and what kind of exercise is being done, and a few other things. Actually, SHBG is so fascinating. There's a lot of ways that one can tweak that levels of SHBG just through lifestyle. And again, if you want a separate program looking at, I could give you a good 2-hour program just on SHBG. It really is interesting, and it provides alternative vehicles for tweaking one's hormones that don't involve prescriptions. So SHBG can change from day to day. And of course, then this will impact the amount of testosterone that will have any real effect. All right. So when you look at these graphs, it's difficult to know, what level of testosterone that person actually has. So testosterone could be involved in some women feeling depressed, actually. And I say may because there are some conflicting findings in the research. And it does remain controversial. So for example, in the 8-year follow-up of the SWAN cohort, women who had increased testosterone levels were more likely to have significant depressive symptoms. However, in the earlier SWAN group, where the women were premenopausal or in the early menopause transition, they found just the opposite. They found less depression. And to add to the conflict, In the 10-year Seattle Midlife Women's Health Study, there was no association between urinary testosterone levels and depressive symptoms. So, why all the confusion? It's complicated. Other factors can come into play, including but not limited to genetic polymorphisms, marital and relationship issues, financial concerns, physical activity, caregiving responsibilities. I've already mentioned the possible connection between lack of quality sleep and depression. But even this can be a challenge to disentangle for all of the same issues. And just an aside, one of the strongest predictors found for poor sleep in the menopause transition is how well or poorly a woman slept during their premenopausal years. So another hint for history taking. In my clinical experience, estrogen and testosterone have always seemed to be in a sort of inverse relationship. And I have one example that immediately comes to mind. Many years ago, I had the opportunity to help moderate a support group for young women who had a surgical menopause. And what I discovered is that these women had terrible issues related to libido and mood. Some were seriously depressed. Of course, they were young and they were now sterile, so that impact was certainly there and needs to be appreciated. But something else was going on, and although many jumped to the conclusion that it was estrogen loss causing the problem, it actually wasn't. They would go to their docs, and believing that estrogen was the answer, they kept prescribing more and more. Some of the women were on 5 milligrams of Premarin daily, which is incredible when you think about it now. That was a long time ago, and even more incredible to me when I look back on it. So what happened? Well, when they were taking oral estrogen, whenever women take oral estrogen, it affects their SHBG levels. They increase. So that results in much more of the testosterone being bound up and essentially useless. These women were getting worse with every increase in estrogen because their bioavailable testosterone was decreasing more and more. So the moral of the story, estrogen is not the only important neurosteroid involved in depression. And sorting through all the possible interrelationships between these hormones in a single woman is not something that can be done using a simple algorithmic formula. It takes lots of critical thinking and analysis related to what a woman's unique situation in chemistry might be. And as I often tell my students, these are not the kinds of things that you can Google in order to get an answer. I feel compelled to add the next few slides because I can't begin to count the number of times women have requested that I order salivary or even serum levels of testosterone. This slide represents salivary T levels in 40 to 49-year-olds, the typical age group looking for this test. These results are from 3 days scattered throughout the menstrual cycle. Look carefully at the variability on each of those days. Even if I were to order free testosterone levels, there's simply too much variability in a 24-hour period for it to provide any really useful information. One sample is sort of like throwing a dart on the wall. Sometimes you might hit it just right, but more often than not, you won't. Furthermore, the range of normal is so wide that you would need to be on one end of the extreme or the other to have it really tell you anything, or anything that's useful. In this slide, what I especially want to point out is the gradual increase that occurs in testosterone beginning around age 44. And that's around the same time that estradiol is starting to experience some new lows. And if you follow it through the next two clumps of data, you'll notice that as estradiol levels are declining, testosterone levels are increasing. Ever so gradually, but still an obvious increase. I used to joke that maybe the 70s are the best years between men and women engaging in sexual activity, because as men's testosterone levels are decreasing and women's are increasing, they might finally be in better sync with each other in terms of their libido. There's a lot going on in the 70s and 80s that no one is really openly sharing with us. And finally, remember those estrogen receptors found all over the brain? Research looking specifically at estrogen receptor beta shows that it's much more important in terms of mood regulation within the brain than estrogen receptor alpha. And what we do know is that phytoestrogens bind much more tightly to ER beta than it does ER alpha. So that's as good a reason as any to increase one's intake of plant estrogens. And with that, this includes the section on estrogen and depression. When you're ready, I'll meet you in the next section, cognition and estrogen.